In this final part of our Chapter 1 breakdown, we are moving from history to the hard numbers and the economic theory that drives the system. We'll examine the cost explosion, how US healthcare spending grew from 5% of GDP in 1960 to nearly 18% by 2020. Most importantly, we will cover the 10 core economic concepts like scarcity, opportunity cost, and market failure that form the foundation for everything we study in health economics. By the end of this video, you'll understand the crossroads the US system faces today and what the future might hold. Section 6, the cost explosion. Spending growth 1960-20 to 20. Let's look at the numbers. In 1960, the US spent $27 billion on healthcare. That was 5% of GDP. By 1990, spending had reached $721 billion and 12% of GDP. By 2020, we were at over $4 trillion and 18% of GDP. Between 1960 and 1990, healthcare spending grew at over 11% per year. That's far faster than wages, inflation, or the overall economy. Why costs kept rising? Several factors drove this growth. New technology kept expanding what medicine could do. Each innovation cost money. Fee-for-service payment meant providers earned more when they did more. There was no financial incentive to hold back. Third-party payment insulated patients from costs. When insurance pays, patients don't see the bill. Certificate of need laws and planning agencies tried to control growth but largely failed. The system kept expanding. Who pays for healthcare? 2020. By 2020, here's how healthcare spending broke down. Private insurance covered about 36%. Medicare covered 22%. Medicaid covered 17%. Out-of-pocket payments from individuals accounted for about 11%. The rest came from other government programs and sources. The public sector now finances over 45% of total healthcare spending directly. When you add in tax subsidies for employer coverage, the government's role is even larger. Section 7, Managed Care and Payment Reform. The managed care response, starting in the 1980s, payers fought back against rising costs. Medicare introduced prospective payment for hospitals using diagnosis-related groups, or DRGs. Instead of paying whatever the hospital billed, Medicare set a fixed payment based on the patient's diagnosis. If the hospital spent less than that amount, it kept the difference. If it spent more, it absorbed the loss. Private insurers followed with HMOs and PPOs. These plans created provider networks, required referrals for specialists, and negotiated discounts with hospitals and physicians. Capitation gave providers a fixed payment per patient per month, regardless of how much care that patient used. The idea was to flip the incentive from volume to efficiency. Delivery system changes, 1990s versus 2010s. The delivery system transformed. In the 1990s, you had independent hospitals, solo practitioners, and patients who could see any willing provider. By the 2010s, the landscape looked completely different. Clinically integrated systems, group and hospital-based physician practices, accountable care organizations, a shift from individual health to population health. Payment system changes, 1990s versus 2010s. Payment changed too. The old model was fee-for-service. Do more, get paid more. Payment came after the service was delivered. The new model emphasizes value over volume. Alternative payment models. Bundled payments, shared savings, prospective payment, risk sharing between payers and providers. The shift isn't complete. Fee-for-service still dominates in many areas, but the direction is clear. Consolidation and market power. The ACA accelerated consolidation. Physician practices merged, hospitals merged. Vertically integrated systems emerged, combining hospitals, physician groups, and sometimes insurance plans under one corporate umbrella. These large systems gained bargaining power with insurers. That power translated into higher prices. In many markets, competition declined even as integration increased. This is one of the unintended consequences of pushing for coordinated care. Coordination can improve quality, but it can also reduce competition and raise costs. Section 8, 10 Key Economic Concepts. Economic Thinking in Healthcare. Henderson identifies 10 core economic concepts that govern healthcare. If you want to understand why the system works the way it does, you need to understand these ideas. Let me walk through them quickly. 1. Scarcity. Resources are limited. We can't provide unlimited care to everyone. 2. Opportunity cost. Every dollar spent on healthcare is a dollar not spent on something else. Every choice involves giving something up. 3. Marginal analysis. Decisions happen at the margin. Should we spend one more dollar? Treat one more patient? The answer depends on marginal costs and marginal benefits. 4. Self-interest. People respond to incentives. Patients, providers, insurers, and policymakers all act based on what benefits them. 5. Markets and pricing. Prices signal value and allocate resources. When prices are distorted, resources get misallocated. 6. Supply and demand. The interaction of buyers and sellers determines prices and quantities. 7. Competition. Competitive markets push prices down and quality up. Healthcare often lacks effective competition. 8. Efficiency. Using resources to maximize social welfare. Inefficient systems waste resources. 9. Market failure. Healthcare markets fail in several ways. Information is asymmetric. Externalities exist. Public goods are undersupplied. Insurance creates moral hazard. 10. Comparative advantage. Specialization and trade can make everyone better off. This applies to providers, institutions, and even countries. These 10 concepts form the foundation for everything else in health economics. Section 9, where we stand now. Progress and remaining challenges. Where does this leave us? The ACA and Medicaid expansion pushed insurance coverage above 90% of the population. That's real progress. But over 30 million Americans remain uninsured. Costs keep rising. An aging population will put more pressure on Medicare. Provider consolidation continues. Political conflict shows no signs of ending. The crossroads. Henderson concludes that the U.S. healthcare system remains at a crossroads. We can stay on the current path and make incremental adjustments. We can try to build on the ACA's strengths while addressing its weaknesses. Or we can pursue fundamental change, whether that's single-payer, market-based reform, or something else entirely. Each path involves trade-offs. Each path creates winners and losers. The iron triangle hasn't gone away. Key takeaways. Let me leave you with the key points from this chapter. The United States spends more on healthcare than any other nation, but results are mixed. Quality, access, and affordability pull against each other. You can't maximize all three. Historical forces from germ theory to World War II wage controls shaped the system we have today. Third-party payment changed the economics of healthcare. When someone else pays, incentives shift. Reform is hard because the trade-offs are real. There are no easy answers. This chapter provides the foundation for everything else in health economics and policy. Every debate about insurance, Medicare, hospitals, and reform rests on these forces. We've covered a lot of ground, from the $4 trillion we spend annually to the 10 fundamental economic concepts that govern every decision in this industry. Whether we move toward further consolidation or a complete market-based reform, the trade-offs of the Iron Triangle remain the central challenge for the next generation of healthcare leaders. This series was based on Chapter 1 of Health Economics and Policy by James W. Henderson. If this was helpful for your MHA or MBA studies, please subscribe to Mastering, MHA, MBA, and leave a comment below with which concept you found most interesting. Thanks for watching, and I'll see you in the next chapter.